Okay, here we are. We can have a look on what the guideline is saying about a previous unsuccessful transvaginal circulation and why we should do a high vaginal instead of low vaginal plate circulation. Because they said that this is going to lead to lower subsequent odds of preterm birth. Right? Is there anything about when should we say that this is unsuccessful or successful? Look here. Preconceptional insertion should be considered when possible because of reduced anesthetic risk and the technical advantage of operating on a uterus of a woman who is not pregnant. But there is no impact on fertility, so take care. And it's not going to affect the fertility. This is one, okay. Verse 2. As you can see, they are not telling us about the 6 weeks gaps or whatever anymore. For me, it's unsuccessful because she still have a preterm delivery. Okay, I opened the guideline with you to show you if there is anything about unsuccessful. It has mentioned here, as you can see. Okay, and this is a very good point, by the way, that the preconceptional insertion is not going to affect the fertility. This can come as SVA also, and lower anesthetic risk. And that's it. Okay, let's get back to our question. I told you there's going to be different answers regarding labor. Okay, this woman. P-prom at 34 plus 6. She had a cervical suture placed at 17 weeks following premature labor in her previous pregnancy, which resulted in a normal delivery at 29 weeks. So this time, that's great. She managed to complete 35 weeks. No signs of infection. CTG is normal, normal Doppler, and the baby is cephalic. She's having P-prom. What are you going to do with the suture? You know why we wait for 48 hours for the removal of the circular suture? Why? Why we wait for 48 hours? For in utero transfer or because you are going to give her steroids, right? Yes, okay. So again, this is very challenging situation. Let me tell you, this one is really challenging here. You have to make your mind. Are you going to give this woman steroids or not? She's not having any clinical infection. And the baby is okay. She's just having a PPROM, and now she is 34 plus 6 weeks. Okay, okay, I'm going to give her antibiotics. Okay, no rule for atosipan here, right? Okay, delaying the removal of cerclage is very risky, guys. The delay of removing the sutures is very risky. So when we have a case that we are thinking about delaying of removal of the sutures, there should be clear indication for this. A clear indication. But it's not like the first line of management. What should be done is to remove the sutures, not to keep it. This is the general rule. We are going to keep it only if the woman is in a real need of corticosteroids or in a real need to be transferred to a better facility. So here, we are having a gestational age of 34 plus 6. Is this a gestational age that you are going to offer corticosteroids routinely for any case of PPROM? Is it a must? This is the question. We're going to consider it, right? But not offer it. This is the difference between offer and consider. Okay, so we have option C, which say give betamethasone and erythromycin and remove the cerclage when there are signs of labor. No, this is not the case. When the woman is having PPROM, we should remove the cerclage sutures. So let me open with you the file of cerclage. I have put it here somewhere. Yes. Okay. Because I know that this new guideline is going to give you headache. I know. So here we are. We have a special case here. We have a special case here. The case is this woman is having a PPROM, right? I'm going to maximize it, you can see. So PPROM cases is really delicate cases. I'm weighing the advantage of waiting versus having induction of delivery and rescuing this baby of having any kind of infection, right? So if the woman is having a PPROM between 24 and 34 weeks, and there is no evidence of infection, this is when I can consider, it's not a routine. Why? Because I want to transfer this patient to a facility where there is a level 3 care, neonatal care. This baby is very early preterm, so he's going to need NICU, right? But here, before 23 weeks, the survival rate of this baby is really low. Or after 34 weeks, when the delayed suture removal is not going to be advantageous. Okay, guys, you got the difference? Have you observed? Okay, we have general rules. General rules. The general rules are, if you are having a transvaginal cerclage, okay, you are going to remove it anyway between 36 and 37 weeks. Okay, if she's having a vaginal delivery, of course. If the woman is having established preterm labor, definitely the cerclage is going to be removed. Definitely. Should I wait? Should I wait until she's having established labor? If she's having PPROM, no, I shouldn't wait. I shouldn't wait. We can have another case, by the way. We can have a case where the membranes are intact, okay? But she's having regular contractions. What are you going to do? Are you going to remove the cerclage or you are going to keep the cerclage? Remove it. Excellent. So this should be clear. This should be clear for you. When I'm having established preterm labor, I'm going to remove the cerclage. Why? Because evidence-based, the cerclage is not doing its job here. Okay, she's already in labor. So why the hell I'm going to need the cerclage? I don't need it anymore. The cerclage should protect this woman from having a preterm labor. I don't want the cervix to dilate, so the sequence of labor is not started. You know, when the cervix is dilated, the oxytocin is going to be released, and the prostaglandins are going to be released. The contractions are going to start up, augmented, and so on. So when a woman is having established preterm labor, this is failed cerclage, definitely. Okay, so I'm going to remove it. In the case here, in this question, I'm going to return to it. The woman is having PPROM. And when we have a PPROM, that means I'm not going to wait. I'm only going to wait if the woman is in the period where the corticosteroids are golden, from 24 to 34 weeks. Those are the golden period for the work of corticosteroids. Before this, it's not going to work. After this, we can consider, but it's not going to be offered for everyone. Okay, and I don't want to talk much about corticosteroids because it needs a separate class, because the new guideline needs a hell of focus. So here, I think that we are going to remove the cerclage and let it be. If the woman is having spontaneous labor, it's okay. If not, I can consider induction. Right? Because of the fear of infection. And here we are. I got you the evidence. Yes, it's old question, but I love it. Here, we have the evidence from the new guideline. Okay, as I told you, it's not going to be a routine procedure to delay the removal of suture. This could be associated with increased risk of maternal fetal sepsis in case of PPROM. Okay? But if we are having a PPROM between 24 and 34 weeks, I can give her steroids. I can make the risk for the baby to go to the NICU less. So yeah, I can wait. I can wait for 48 hours and give her the steroid. After 34, it's not going to work. Before 23, definitely it's not going to work. I hope it's clear. Okay, love this one also. A 28-year-old G3P1, she is contracting 5 in 10. Wow. And she is 34 plus 4. Her previous delivery was by cesarean section for failure to progress at 4 centimeters. If this woman is going to continue with vaginal delivery, is it what we are going to call it? Until here, I didn't finish the scenario, but if this woman is having established labor and she's dilating, yes, VBAC, excellent. Yes, VBAC, and it's okay. But here, the woman is fully effaced, 3 centimeter footling breech presentation. Without even going further with the scenario, please give me an answer. The appropriate immediate management. Yes, definitely. And I'm not going to tell you that some of the candidates choose internal modalic version, and I don't know why. Footling equal CS. Footling equal CS. That's it. Excellent, guys. Okay, we can have a deep breath outside circadian labor for some time, and let's talk about perineal tear. At least you are going to be able to answer this one correctly, inshallah. Yeah, she's like a ticking bomb. Previous CS and footling. Yeah, a definite ticking bomb. But it's not about previous CS, Dr. Faiza, you know? If she's only having if she's having a cephalic baby and she is having a fully effaced cervix, I can go for VBAC. The only thing that hold me back is the footling presentation. To hear someone give me the level of the tear, which group? Less than half the thickness of external sphincter is torn. Excellent, excellent, excellent. Yes, third degree perineal tear, but we are still in 3A. 3B, when the thickness is more than 50%. 3C is when internal sphincter is torn, okay? And what would be the fourth degree perineal tear? When the tear reach the rectal anal mucosa. Excellent. Okay, what would be the gold standard technique or gold standard investigation to follow up this woman, okay, and specifically when she's going to have a delivery again in subsequent pregnancy? Anal mucosa, to be specific, anal mucosa. Endoanal ultrasound. Yes, endoanal ultrasound. This is the gold standard investigation. This is going to assess the depth of tear, any residual sphincter abnormalities. The site, of course. Okay, so we can make our mind about, shall she go for vaginal delivery or she should have a cesarean section? Okay, so let me ask you a question that is very trendy lately. A woman with a previous third-degree perineal tear, and she comes for counseling now at 36 weeks of gestation in this current pregnancy. The endoanal ultrasound shows residual complication or residual tears. Okay, the woman is embarking on vaginal delivery. What would you do? Are you going to convince her with cesarean section? Are you going to refuse her choice and book her for elective cesarean section? Are you going to refer her to the consultant? Are you going to consider her choice and tell her that she should have delivery at a consultant-led care unit? Excellent. Respect her wishes. Respect her wishes, guys. But you should tell her the pros and cons, and you should book her for consultant-led care unit. She cannot have delivery at home. She cannot have delivery at the midwifery unit. She cannot have delivery at the normal labor ward. No, this woman should have delivery at a consultant-led care unit. This is a very trendy question lately. Okay, so here, this is also a very good question. Following a repair of third degree tear, it's 3B, what should you advise the woman in immediate post-operative period? warm dehiscence and ما أدراكم ما warm dehiscence questions. Yes, we are going to do anything that decrease the risk of warm dehiscence. Definitely, this woman should not strain. Okay, this woman should have bulking agents. No, you know why they are asking you so? Because mainly when we offer laxatives to normal people, we have to give some bulking agents with it. Okay, yeah, to decrease the risk of severe diarrhea and mineral loss in stool. So we need some sort of absorption, but also we need a soft stool. So we give laxatives plus bulking agents. In this case, in case of perineal tear, we only give laxatives, no bulking agents. Okay, physiotherapy is amazing, of course, and definitely should going to be at increased risk for recurrence. And definitely we are going to give antibiotics. Which kind of antibiotics you are going to give this woman for prophylaxis? No, this is not what's mentioned in the guideline. Yes, a broad spectrum antibiotic. The most famous one is called amoxiclav or augmentin. It's post-operative there. It's post-operative for prophylaxis. So your wound is not going to be infected. Metronidazole is going to kill only the anaerobes. So no, we don't offer metronidazole. After episiotomy, after episiotomy, not the repair of perineal tear. Is it a must to give antibiotics or not? You provoked me. You provoked me. So this is why I'm asking. According to the NICE guideline, are you going to routinely give antibiotics or not? Routinely? Routinely? No. Routinely, no. Case to case, yes. According to the case. She may have meconium, amniotic fluid, meconium stained fluid, for example. The woman or the theater, you are suspecting that it's not really hygienic. Or the woman, she had episiotomy in a different facility, and you are suspecting that this facility is not really hygienic. The woman is excellent. She's having low immunity, for example, and she can have a bad wound healing, like diabetic. But it's not a routine. Now we have routine giving for antibiotics, okay, in two situations. Before CS, okay, at least one hour before skin incision, or by the time of induction of anesthesia. Okay, the other one is instrumental delivery. The third one is after perineal tear repair. Okay, excellent, excellent, excellent. Okay, let's see if we are having a second question here in this file or not. Do you know the answer for this question? A technical one, but it's also good. Any idea? Okay, I'm getting one answer. So the anatomical structures involved, what suture material was used, what analgesia was required, post-operative plans, including advice in future pregnancy, and episiotomy should be performed in order to avoid a recurrent third degree tear. Are you serious? Yes, no, we never do routine episiotomy. The evidence behind doing routine episiotomy to avoid a recurrent tear is really poor. You again provoke me to answer to ask you a question. Yes, the correct answer here is A, okay? The anatomical structure, the method of repair, suture material, rectal examination is performed or not. Okay, that's going to be the most important points to document. Okay, now let me ask you a question. What would be the evidence-based maneuver that can decrease the risk of perineal tear according to the guideline? What it would be? There is a measure or a maneuver that can be done that can decrease the risk of having a perineal tear. Is it perineal support during delivery or perineal massage during delivery or warm compressing or warm pads or episiotomy? I'm really proud of Dr. Laila and Dr. Sidra. The one that we are sure about is the warm compressors. Yes, this is the one that we are sure about. Come next. Come next is the perineal support, but it's going to be individualized, or let's say it's going to depend on the doctor. Some doctors can really do a good perineal support. Some of them do the perineal support, but it's like nothing. They are doing nothing. And I usually got like one scream or two from my seniors when I was in my first year. You are not doing a good support. This is not a good support. And I'm like, okay, I don't know what else should I do. I'm having a very small hand. So my hand is not like covering the whole area. Wallahi, that's true. So it's individualized. It's going to differ from one practitioner to another. But the one that we are really sure about is the warm compressors. So remember this because I think it's a recall, if I'm not wrong. You can laugh, yeah. Okay, this one. Let me hide the answer. This is a totally exam question also. Type of suturing, okay, and the suture material, because they are mentioned in the guideline. I remember I had only one near urethral tear, and near, not a urethral tear. It was very near to the urethra. So I'm not going to forget it ever. Dr. Faiza, we are answering according to the guideline. So yes, of course, you can use a warm towel and do the support. 2 in 1. But they are going to ask you what would be the maneuver that reduce the risk. So even perineal massage, this is not of the one that evidently based proved to reduce the risk of perineal tear when it's done during labor. When it's done antenatally, yeah, yes, it can do something. If the woman is going to practice perineal massage, this is amazing, by the way, but not during labor. So here you answered A, and to end anastomosis with 30 PDS. Okay, let me see the question. Anal sphincter. Yeah, okay. So I always remember it this way. I always remember it this way. The anal sphincter is the innermost layer, right? and then the mucosa, of course. But if you overclosed or over approximated the anal sphincter, this woman is going to cry out loud and curse you every day until she dies. And she could have a corrective surgery because of what you have done. So remember, when you are dealing with internal sphincters like anal sphincter, not the external one, okay? You have to do end to end, not overlapping. When we are dealing with external anal sphincter, we can do overlapping or end to end, whatever you wish. Got it? Why? Because I don't want the anal opening to be very tight. So this woman one day is going to have a corrective surgery and dilatation of the anal opening. You know what she's going to do? She's going to go for a general surgeon, and the general surgeon is going to cut her sphincter. He's going to undo your repair. So when we are dealing with the internal anal sphincter, don't do overlap. Do end to end. Just approximate the endings of the sphincter because I want the sphincter to work, but with no over approximation. Here, they didn't mention whether it's internal or external. So there is a trick, of course. The trick is with the type of suture. Okay, so we have to choose one that can work for both, for externally and internally. And this would be the 3-0 PDS. The 3-0 PDS. Can we use the 2-0 Vicryl? Yes, we can use it if it's in case of what? In case of external sphincter, excellent. Excellent, guys. Okay. And yeah, definitely PDS is the best. Okay, because it's going to be reabsorbed by the body with a longer time, so better healing, better approximation, strong one, excellent. But we are having the risk of infection more with the PDS. So this is why we're going to cover her with antibiotic. Okay, excellent. I'm getting correct answers. Definitely, we are going to avoid the fundal pressure. Yes, fundal pressure plus shoulder dystocia, and you will have a nice uterine rupture. Okay. So, yes, this woman. Take your time. Think about it. The woman already had antenatal steroids at 28 weeks. When she came with the same presentation, intermittent lower abdominal pain, the TVS showed cervical length of 18 millimeter. Okay, when I see this, I'm going to remind myself again. What is the gestational age here? It's 31 weeks. So what do you think? Should I do a cerclage here? No cerclage. Excellent. Okay. Can I give her vaginal progesterone? It's not A or H because we are not going to offer nifedipine unless we are having a regular contraction. And this woman is having intermittent lower abdominal pain. They also told you that her urine dipstick is negative. There is no PPROM, there's nothing. You know why no treatment required? Someone, please, please, if you are awake, tell me why not endomethacin? She's having pain. So why not endomethacin? PDA because she's 31 weeks. Excellent. Excellent. So if a woman like this woman comes to me with lower abdominal pain and the pain is intermittent, there is no gush of fluids, there is no cervical dilatation, okay? I'm going to give her a painkiller. Usually non-steroidals are amazing, okay? But non-steroidal after 30 weeks, we are talking about high risk of premature closure of ductus arteriosus. Yes, excellent, Dr. Pfizer. This could be Braxton Hicks. So here, no treatment required. Not magnesium sulfate. Magnesium sulfate is given when you are having established preterm labor and the woman is suspected to have or expected to have delivery within 24 hours. Yeah, you can give her paracetamol, of course. Okay, agree? Are we all on the same page? Okay. Yes, there's one here also. Yes, this one. Do you have any idea? We are not going to do a fundal pressure anyway. And take care, I'm not talking about mortality, I'm talking about morbidity. Mortality, definitely fundal pressure is going to kill her. She can have a uterine rupture and bleed until death. But here, morbidity. Yeah, I got some correct answers. Yes, symphysiotomy, which is cutting the subsys pupus. Right? Yeah. This can lead her to a serious maternal morbidity. The least of it is pain. The least of it. Okay. No. Oh, yeah, yeah. This one. I'm having a woman, 34 weeks. She's having preterm, pre-labor rupture of membranes, and we make sure that this is true. She's having pooling of liquor in the vagina. Which of the following is the most appropriate treatment? Excellent. Erythromycin, 250, 4 times. Excellent, guys. See, I'm not a fan of AMQs, but sometimes they are like a gift. Okay, this woman. See, she is delivering in a standalone midwife-led unit. She's low risk. She had Pethidine for pain relief, and now she's having shoulder dystocia, which has not been resolved by my croppers. So now I know for sure that they are going to ask me about the best next step. Do you remember the flow chart? What should we do after having macrobert plus suprapubic pressure? And by the way, we are only using suprapubic pressure to augment the effect of macrobert. If you don't remember, we can go through it. Because I'm having different answers, and some of you have been taking care that this woman in a standalone midwife-led unit, so some sort of things is not going to be done. She's not going to be able to do it. Okay, let's go. Let's go quickly. We're having here the systematic approach to manage shoulder dystocia. Okay, we all agree that the immediate thing that we all should do is call for help. Okay, and it should be clearly stated. This is shoulder dystocia case for the arriving team to come. No fundal pressure should be used. Macropert is rapid and effective. However, sometimes it fails. Episiotomy is not always necessary. Okay, even if and no internal maneuvers in a standalone midwifery unit, no. We are going to ask the patient to stop pushing. Okay, and we should do something. We should do something. What would be this thing? All four. All four position. You know what's all four position? This one. She's going to have like, I wish I'm having it here. Yes, this one. This is the all four position. It's like sujood in Muslim prayer. Okay, yeah, knee chest position or hands and knees position. So in a midwifery standalone unit, she cannot do internal maneuver. She can ask the patient to go all in four. Okay, this is why the question is good. Okay, then what can we do? What can we do is, here we are. We are going to consider episiotomy if you are going or willing or there is expertise to do internal maneuvers. Internal maneuvers could be many things. Okay, and you can do whatever is accessible to you. You can deliver the posterior arm, and routinely episiotomy. Sorry, episiotomy is not a routine. It's not a routine. Consider it. Consider if it's going to make your management easier, if it's going to give you more space, but it's not a routine. Again, it depends on the operator experience. Okay, and you can do whatever you want. You can deliver the posterior arm first, or you can do the internal rotational maneuvers. If all of them fail, again, you should consider all four positions, or repeat whatever from the above. Okay, so here it really depends on what's there. Are you having a consultant or not? Are you having a senior or not? Is the woman is having a previous vaginal delivery? Is if she's the primary? I don't know the situation. Okay, here we are having both macropod plus the suprapubic pressure. Suprapubic pressure is meant to augment the effect of macropod. And sometimes in the recall there is a question about macropod. Is it adduction of the thigh or abduction of the thigh? It's a really silly question. Okay, don't forget about repeating the maneuvers. Don't forget about trying either delivering the posterior arm or going for internal rotational maneuvers. They are not going to ask you in this gray area. I don't think so. Not for something that is case to case. Okay, so here, this is the exam question, for example. Which maneuver should be performed first in shoulder dystocia? Yes, whenever you are suspecting shoulder dystocia, bring the woman legs and push it to her abdomen and keep it away from each other. In simple words, you're going to open up her thighs and push it towards her tummy. This is the McRobert position. It helps, definitely it helps. I have seen it by my own eyes. It really helps. Plus, you can augment it by the suprapubic pressure, not fundal, not fundal. We are trying to do what? We are trying to release the shoulder inside the, sorry, beneath the symphysis pubis. Okay, to slip the shoulder beneath the symphysis pubis. Then, if the McRobert position fails, I can try all four position or internal maneuvers. Okay, I hope it's clear. Okay, this one is good. What type of delivery may result in a small increase in risk of an adverse outcome in a low-risk nulliparous woman with a cephalic presentation at birth? We have two questions here. Which one is going to have increased risk in adverse outcome, even if she is low-risk nulliparous woman? I'm having like a collection of answers. She's low risk. Okay, so why she's going to need a vaginal breech delivery? She's low risk. Okay, those are two. Yeah, home birth, simply. Okay, this woman with a low risk antenatal history, what would be the most appropriate place or type of delivery? Of course not CS. Yeah, she's low risk. Everything is good. So birth in midwifery lab unit would be amazing. Nothing else. I don't want anything else. We are not going to offer someone to have a home birth. Why we are here, right? Even she is a low risk. This is not one of the options that I'm going to offer her. If it's her choice, this is okay. This is her choice, but I'm not going to offer her home birth. Okay. Um, no, we're not talking about placenta today. I think we had this done. Yeah. Okay. Um, one or two questions about breach, and I'm going to release you. Okay. This is of a question that are really famous in the exam. Delivery of a breech twin. Take your time. This woman is 33 weeks. She's having monochorionic diamniotic twins. Okay. Twin one is delivered uneventfully. Everything is good. Twin two is breech but high up. Contractions are adequate, but 30 minutes have passed, and now the CTG is suspicious. I guess this is a strategy question. He's high. How you are going to do a breech extraction? The baby is high. The CTG is suspicious, and 30 minutes have already passed. This is a clear one, guys. Yes, exactly. It's cesarean section, definitely. Definitely, because the baby is high, the CTG is suspicious, and we have a time frame to work within. We have a 30 minutes between the first one and the second one. Already the 30 minutes have passed, right? Okay, the second one. Do you know the term breach trial? By the way, it was mentioned in the talk article also for management of term breach. This is one of the biggest trials regarding management of term breach. Okay, and the biggest outcome of this trial is the thing that really reduced the perinatal mortality was those who have delivered by cesarean section. You should have high index of suspicion, and you should be like always alarmed. If anything go wrong with a breech labor, you should go quickly for CS. Don't have this trial and error. We would say, I'm going to see the CTG. No. If anything go wrong with a breech delivery, go for cesarean section. So this is the outcome of the term breech trial. And it was mentioned not only in the guideline, but also in the recent talk article. Okay, this one is good, and I'm going to end with uh, question number 9. Okay, question number 8. For assisted vaginal delivery, for a breech, of course, the Bern-Marshall method involves delivering the baby by extension. The Morrisseau-Smalley V method involves delivering the baby by flexion, by placing one finger in the baby's mouth and two fingers alongside the nose. The pelvic grasp in love-stick maneuver is a routine part of delivery for delivering baby's arms. Upward traction should only commence when fetal chin has reached the perineum. Wrigley forceps should always be used to deliver the fetal head. Which one is correct? It's like a revision over the maneuvers. Okay, I'm having a great answers, and we are going to revise over the maneuvers. Okay. Of course, A, B, C, and E are wrong. Okay. Wrigley forceps should be used only if you are going to deliver the fetal head by CS and it's impacted. Okay. Pelvic grasp in lobstick maneuver is a routine part. Who can remember the lobstick maneuver? But do you agree, all of you, that D is the only correct one? Upward traction should only be commenced when the fetal chin has reached the perineum, right? Now let's have a look. Okay, here we are having some problem that can happen during the breech delivery. The first one is when you are delivering the lower limbs and trunk. This should be spontaneous descent of the baby's body. But if the baby's leg are extended, I should do what? I can flex one after another by applying gentle pressure in the popliteal fossa. Okay, so then I'm going to get the babies back to the normal position. This would be the normal position. And when it's easy, of course, for the body by this position to come out, and then when the baby's chin is at the perineum, I can go for the upward traction. The delivery for shoulders and arms. Normally, the trunk is going to descend spontaneously. The tip is going of the anterior shoulder is going to appear. If the baby's arms are flexed, then it's going to be very easy for the shoulder to come out. But if the baby's arm is not flexed, then we can do the love step maneuver, which is I'm going to make arm flexion. I'm trying to mimicate or mock the normal baby situation. If he is a normal breech without any complications. Here, the delivery of the aftercoming head. Normally, it should not take any time. If the baby's head is adequate with the pelvis and everything, only a gentle suprapubic pressure is going to slide the baby's nape of or back, the nape of his head, underneath the symphysis the symphysis pubis bone. Right? But if this is not successful, I can do the MCV maneuver. In the MCV maneuver, it's not a must to insert your fingers inside the baby's mouth. It's not a must. What's a must is to apply your hand over the nape of the baby to support it here and to support it here. So you are not doing overflexion or overextension. You want the baby's head to be under control and the neck. So when you do this, you are doing the normal movement of the head coming out, but with your own hands. Sometimes the baby is going to be hanged like this. You can do what's called the Burns-Marshall method. Burns-Marshall method is to apply your fingers over the baby's feet and turn him away, like you are tossing something away. This is going to slide the baby's nape of head underneath again the symphysis pubis bone and make it rotate to the normal position. Let's get back to the question, and I know it's a silly one. Okay, here, the MRC or MRCV maneuver, okay, or MCV maneuver. We are going to place one finger in the baby's mouth, but not with two fingers alongside the nose. We are doing the two fingers along the nape of the neck and the chin. The pelvic grasp in love set maneuver, there is no pelvic grasp as a routine part of love set maneuver. It's not a routine one. We are going to flex the hand. Wrigley, as I told you, is only used when we are delivering the impacted head of a breech during CS. Burns-Marshall involved delivering the baby by extension? No, it's not by extension. Definitely not by extension. I'm doing this to do a sort of flexion of the head, this quick or rapid movement to twist the baby away, because I want this to be flexed, the chin flexed on his chest. So to slide the nape of the head underneath the census pubis. Okay, the last one, guys. Fetal head entrapment during vaginal breech delivery. What you are going to do. This should be quick, come on. Yes, 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 excellent. And here we are, if you want to take a screenshot. Those were the answers for the previous one with the maneuvers. Okay, and if you are still in doubt, love set is not a routine part of vaginal breech delivery. Okay, and yeah, when we do the uh, flexion of the elbow joint or flexion of the baby or rotating him away through a 180 degree in opposite direction. Okay, I'm trying to put the baby back on the normal position. Okay, the aftercoming head. When I see the nape of the neck visible, now I can do the MSV, right? And now I can do the gentle suprapubic pressure. Both of them, I mean, or I intend to do what? I intend to flex the head as much as I can. So it's going to slip underneath the census pubis. Okay? As you all said, for the fetal head entrapment, we are not going to do the Duchenne incision at 3, 6, 9 o'clock unless you have already rotated the body to the sacrotransverse position. This is very invasive, by the way. But again, I know you are tired, and this is what happened in the exam, by the way. So you always think about what you can do, like really do, a surgical maneuver. Okay, so here we are again. We are going to call for help. Perform a Robert maneuver as if this is a shoulder dystocia. Apply suprapubic pressure as if it is a shoulder dystocia. Then we can do the MSV maneuver. Then we can rotate the baby to sacrotransverse position. This is going to help. Okay, we also can administer autocolysis. We can attempt a forceps delivery. When everything fails, yeah, you can do the cervical incision. And if you are in emergency, take care, but because I know that this is the recall. And I know that the scenario in the recall was talking about emergency breach. The baby was like having a pathological CTG or something like this, or it has been like over 30 minutes or like 2 hours in second stage, something like this. So you are you want to get the fetal head quickly. Don't go for cervical incisions unless you tried those steps. Agree or not really? I really want you to go through this top article because it's really amazing one. The management of breached term breach. The really talks also about when you are going to use the forceps. Okay, so forceps is one of the maneuver that we can use if you have already tried the MSV maneuver and the head of the baby is not out yet. You can use pepper. You can use Keeland if pepper is not there. And I'm not sure if this was a recall or not, but I think I have seen this question somewhere. Which kind of forceps are the best for delivering the after coming head of a breech? Pepper is really good. If it's not available, then Keeland. If Keeland is not there, then any type of mid-cavity forceps can be used. You are going to rotate the baby's body to sacrotransverse position. It means you are going to put the sacrum of the baby, and instead of being an anterior, you are going to rotate the baby 90 degrees. Got it? We never use regularly for vaginal breech birth. I wish we can have more time to discuss more questions. And I really wish if you can put your questions and queries in the group. Okay, we can help each other. So guys, thank you so much for being here today. Really, thank you. Wish you all the best. I know labor is going to take some work from you. Try to answer as much questions as you can and take care of the old answers. Okay, until now we have a new guideline for corticosteroids, a new guideline for the cerclage. What else? Remind me. And we are going to have a new guideline for breach soon, by the way. They are writing it. So let's see. Thank you so much. Take care, everyone. Have a great night. Thank you, Dr. Laila, Dr. Rasha. Thank you, thank you. Shahzadi, I love your name. See you soon, everyone. Salam alaikum.